growing and I think urgent national concern, which is the mental health crisis that is ravaging our nation, and including and especially our nation's seniors. It's a topic that too often is discussed behind closed doors due to the unrelenting and unwarranted stigma attached to this issue. It's estimated that one in four older adults experiences a mental health condition, including depression, anxiety, or substance use disorder. In 2020, Americans who were 85 years of age and older had the highest suicide rate of any group of Americans. Many seniors are in pain and struggling to find help. In the year before the pandemic, more than 30,000, just by example, in one state, 30,000 Pennsylvanians looked to the state mental health authority for support. I imagine that number would be even higher if more seniors knew that this kind of care was available. And again, that was before the pandemic. The pandemic has only worsened this crisis, as older adults have been forced to isolate in their homes, away from their family and friends. The resulting social isolation and loneliness has taken a terrible toll on older adults across the country. Research shows that social isolation has the same adverse impact on health as smoking 15 cigarettes a day, and it's correlated with an increased risk of depression. So today we'll hear from a panel of witnesses who will highlight the gaps in our mental health system, particularly for older adults, and they will offer solutions. We'll hear from Jim Classen from Elkins Park, Montgomery County, Pennsylvania. Jim and his family know the harsh realities of stigma all too well. He knows the unfairness of being judged for needing help with a mental health condition. In his testimony, Jim says the support he has received enables him now to share his experience without shame. The reality is that too many older adults today face fragmented systems and roadblocks that prevent them from accessing the support that they need. Both the Congress, House and Senate, and the Biden administration are focused on this issue, and that's good news, but we've got to get a lot more done. President Biden recently announced that his Unity Agenda, which calls for expansions in the mental health workforce, and also that promotes mental health care itself in the community. So that's important, and it's a big step forward. But it's now time for the Congress to act. Ranking Member Tim Scott and I are introducing a bipartisan resolution, the very first of its kind to raise awareness about the impact of mental health conditions and substance use disorder on older adults. Today, Ranking Member Scott and I will also be introducing the Advancing Integration in Medicare and Medicaid Act, which will require states to develop a plan to address the fragmentation in Medicare and Medicaid. These are the very programs which so many older adults rely upon for their mental health. I'll be introducing as well a bill to give states funding to execute these plans so that individuals can have meaningful access to all of their health care needs. This includes primary care, mental health, as well as long-term care and more. So we've got work to do, but we're grateful that we have this opportunity to have this hearing today, and I'll now turn to our Ranking Member Scott.
Thank you, Chairman Casey, for holding another truly important hearing. To the guests, panelists, thank you so much for participating in this process. It's without question, your expertise will lend itself to us uncovering more solutions and providing more assistance to those who are certainly in need of that assistance. I'd also like to take the time to recognize the students behind the witnesses, the University of South Carolina's pharmacy students who are part of the Walker Scholars Program. They have decided to join us for the next 3 or 4 hours. I appreciate y'all sticking around for the entire time. That was my joke, and no one thought it was funny. But the good news is it wasn't that funny. But the truth is I am always happy to see folks in the room from my home state, and thank you so much for taking your time and investing a part of it in this important topic. And without any question, as the students are here with us, it really is important for us, Chairman Casey, to stress the importance of the Mental Health Awareness Act that we have both sponsored. The truth is that too many of our seniors and frankly our general population continue to feel this heavy weight on their shoulders, and it is one that is palpable. I think it's true at all ages. There's no doubt that the suicide rate amongst our youngest Americans is way too high, and the same is true with our seniors. I was talking to someone recently, just yesterday, and we were walking through on one of my constituent calls the rising crime and the officers that have been shot at a record level and the highest number of incidents focusing and targeting our officers and, frankly, the nation's history. We watched in Buffalo another racist attack. You go to the gas pump in South Carolina, the gas price has doubled in less than 2 years. The fact of the matter is, if you're involved in an accident, which actually happened to the constituent's son yesterday, there are no rental cars. Parents who are looking for formula can't find it. There are reasons why Americans feel a level of burden and stress and challenges. It's the fact that economically, crime, safety, security, loneliness, I think it was Surgeon General Merther who said that loneliness is like smoking 15 cigarettes a day. And just thinking about that is a lot for the average person coming out of a pandemic, and the lingering effect is undeniable. That's why I'm so thankful that Chairman Casey and I have worked diligently in a bipartisan fashion. There are many Americans who think nothing in Congress ever happens with the two sides coming together. Simply false. The truth is, all that we accomplish in the United States Senate requires a bipartisan coalition, and that is a blessing to the great United States of America. One of those is the AIM Act that Senator Casey has already described. Another one that I'm working on is the Academic Act. It authorizes a comprehensive study of the long-term impact of COVID-19 and associated school closures, especially on children from low-income families. This bill is sponsored by Senator Rubio, Chairman Casey, and myself. Substance abuse, of course, and overdose deaths are skyrocketing as a result of the mental health crisis that we've seen for the first time. Overdoses have exceeded 100,000 in America, around 107,000, more than car accidents for the first time. The lifetime odds of dying from opioid overdose are now higher than those car accidents. To tackle opioid misuse and raise awareness, South Carolina launched a campaign called Just Plain Killers, particularly among the aging population of prescribed opioids for chronic pain. In addition to the substance abuse, many seniors were plagued, as Senator Casey said, with loneliness. And I will do my best not to reiterate what he has said unless it's just necessary. And sometimes it's necessary to emphasize or reemphasize the importance of the challenges that so many of our seniors face. Also, in addition to that, I mentioned the deaths of our law enforcement officers, and the worst situation for those officers is to go to a domestic situation. It's one of the reasons why in Richland County, law enforcement officers received over 2,700 calls just in a year related to mental health crisis. Not a crime, but a crisis. So we have legislation that focuses on the importance of co-responders so that you actually have officers and mental health experts going to the scene so that we can address the issues in the home without making it necessarily a crime. These are some of the topics that we will discuss and some of the important issues that we will have to face as a bipartisan coalition of people who believe in the future of America, and we are going to get it done. Thank you all for being experts and providing your expertise with us today.
Thank you, Ranking Member Scott. I'll next turn to witness introductions. I'll do several, and Ranking Member Scott, I know, will do one of our introductions. Our first witness is Dr. Aaron Emory Tubercio. Dr. Emory Tubercio is an associate professor of geriatric and rehabilitation psychology and co-director of the Center for Excellence in Behavioral Health Disparities in Aging at Rush University Medical Center. She has a PhD in clinical psychology and completed her fellowship in clinical geropsychology. Thank you, Doctor, for being here with us today and sharing your expertise with the committee. And we'll turn next to Ranking Member Scott.
Thank you, Chairman Casey. It's my honor to introduce to all Dr. Ken Rogers. He helps South Carolinians navigate the mental health system as the director of the South Carolina Department of Mental Health. The department operates 16 community-based outpatient mental health centers, clinics across all 46 counties, and 3 hospitals, including one for addiction treatment. A long history of working to expand mental health services to underserved populations. He collaborates with traditional and non-traditional partners, including law enforcement. He is a native of the area called Dillon, South Carolina, and a graduate of the University of South Carolina School of Medicine. He completed his general psychiatry residency and a child and adolescent psychiatry fellowship at the William S. Hall Psychiatric Institute at the University of South Carolina. He earned a Master's of Science in Public Health from the University of California in Los Angeles. He is bicoastal. He holds a Master's in Medical Management from the University of Southern California. Prior to coming back to South Carolina, he was the Chief of Psychiatry at Parkland Health and Hospital Corporation in Dallas, Texas. In his testimony, Dr. Rogers will talk about his department's work in providing mental health services and the pandemic's impact on mental health, especially for caregivers and our veterans. We look forward to hearing your testimony, and we thank you sincerely for being here.
Thank you, Ranking Member Scott. Our third witness is Kimberly Williams. Ms. Williams is President and CEO of Vibrant Emotional Health. She has overseen the expansion of Vibrant's community-based programming to support older adult mental health. I want to thank Ms. Williams for being with us today and sharing your expertise with the committee. And finally, our fourth witness is Jim Classen from, as I mentioned earlier, Elkins Park, Pennsylvania, Montgomery County, right near Philadelphia. Jim will share his recovery journey with the committee. He's a certified peer specialist facilitator, advanced level WRAP RAP facilitator, and certified older adult certified peer specialist trainer. He brings over 40 years of experience in human services and in the workforce development field. Jim, I'm grateful you're here with us today, and I hope that picture you took with me earlier doesn't get in any trouble back home. But thanks for being with us today. And so we'll turn to our first witness, Dr. Emory Tubercio, if you'd present your testimony, and then we'll go to our next witnesses. Thanks very much.
Thank you so much. Good morning, Chairman Casey, Ranking Member Scott, and distinguished members of this committee. Thank you so much for the opportunity to speak with you today about mental health and substance use issues. My name is Emory Tubercio, and I co-direct the Rush Center for Excellence in Aging at Rush University Medical Center in Chicago. The White House has recognized mental health and substance use as critical issues for all Americans, and I am grateful that this committee recognizes that older adults' needs are an issue of equity. Not only is stigma about mental health and substance use a barrier to effective screening and treatment and assessment, but that stigma is compounded by systemic ageism that has resulted in severely lacking access to care for older adults. Today, I'll point to 3 key issues for this committee to consider in terms of the need for coordination for care for older adults who experience the most complex health issues, and access to care related to Medicare policies, and finally, the critical need for behavioral health workforce trained to work with older adults. I co-direct the SAMHSA-funded E4 Center of Excellence for Behavioral Disparities in Aging, which has offered policy academies in 3 states, Illinois, Nebraska, and Pennsylvania, in our first year and a half. These 3-part events bring together leaders of state entities from aging, mental health, substance use, transportation, housing, and others who rarely communicate with each other in their silos. And we bring them together for facilitated discussion to identify and fill gaps in meeting the needs of older adults with mental health and substance use issues. We are honored currently to partner with the Pennsylvania Association of Area Agencies on Aging in our current Policy Academy. This committed and passionate group of Policy Academy members have highlighted these three issues, which we've seen in other states and across the country, in addition to the importance of telehealth and broadband access. Thank you, Senator Scott, for your fantastic work in this area. Older adults with mental health and substance use issues are more likely to have mental health, chronic medical conditions, multiple medications, multiple health care providers, and multiple community-based organizations providing services, all of which put them at incredible risk for falling into the chasms of our fragmented healthcare system. So, and because supported housing in the community is rarely available or paid for, older adults with serious mental illness are more likely to be placed in an expensive nursing home that they don't want to be in and is ill-equipped to meet their needs. So providing reimbursement for care coordination across health systems and across community-based organizations for older adults is not only critical for equitable care, but has been shown to reduce costs, particularly for individuals who are dually eligible for Medicare and Medicaid. These dual eligible older adults, and quite frankly, every older adult with Medicare, struggles to find available mental health and substance use services. Part of the reason for this is that Medicare reimbursement rates for older adult mental health and substance use is inadequate for engaging providers to enroll. Given that the highest rate of suicide, as you just highlighted, Senator Casey, is among older adults, this lack of available mental health service is deadly. Allowing for market rate reimbursement for mental health and substance use services is critical to assure that adequate provider enrollment. And further, consideration must be given to allow master's level clinicians eligibility to enroll in Medicare so that therapeutics relationships don't have to end just because someone turns 65. An additional challenge is that a tiny fraction of the required behavioral health providers with specialized training in working with older adults are available. So in fact, some states don't even have a single board-certified geropsychologist or geriatric psychiatrist. I'm the only one in the state of Illinois. We are so grateful to Senator Casey for being a champion for funding the Geriatric Workforce Enhancement Programs, or GWEPs as we call them, which are tasked with educating the healthcare workforce and the community about older adult health, along with transforming primary care to be age-friendly. Proposed support for additional GWEPs with larger budgets and, critically, increased focus on older adult mental health and substance use would allow every region of the United States to have access to that high-quality training. And finally, while children and families have been a consistent focus, which is important, federal mandates for SAMHSA have not included older adults. With the unprecedented increase in older adult population in the U.S., legislation to mandate the permanent inclusion of older adults in SAMHSA priorities is desperately needed, along with expanding the HRSA-funded graduate psychology education and teaching health center graduate medical education programs. I am grateful to this committee for considering including access to care related to Medicare policies, coordination of care for older adults with complex health issues, and the critical need for expanding the behavioral health workforce trained to work with older adults. Thank you so much.
Well, Doctor, thanks so much for your testimony. Before turning to Dr. Rogers, I want to note the presence of Senator Collins, former chair of this committee. Dr. Rogers?
Thank you, Chairman Casey and Ranking Member Scott, for the opportunity to be here today. The South Carolina Department of Mental Health is a comprehensive statewide health system that is comprised of 16 mental health centers that cover the entire state and provide whole person care, meaning that we're focused on both the physical and mental health care of our patients. We work in concert with federally qualified health centers, health systems, as well as non-traditional locations of service, including schools, churches, and other community partners. Additionally, we operate 2 freestanding psychiatric hospitals, an inpatient substance treatment facility, and 5 veterans nursing homes. Like all states, South Carolina has seen an increase in the number of individuals seeking care throughout the pandemic. The 2 populations of greatest increase are the youth and the elderly. We have identified several reasons for this increased service need. First, social isolation has had an incredible impact on our elderly population. The activities that seniors in South Carolina often find helpful, such as attending religious services, going to day programs, among other community services, have been unavailable during the pandemic. Secondly is a sense of loss that has been experienced. Over 1 million Americans have died from COVID or its complications. Greater than 75% of those COVID deaths were among individuals ages 65 and older. The majority of elderly individuals have experienced at least one personal loss over the past 2 years, further complicating issues that in many programs serving the elderly have shut down or moved to virtual platforms during the pandemic. The expansion of telehealth has been able to fill this void. SCDMH, the Department of Mental Health, cares for approximately 100,000 individuals yearly. 20% of those individuals are older than age 55. In April 2020, the department moved all of our services virtually and telephonically. Within 2 months, we had contacted 99.9% of all the patients that we were seeing pre-pandemic. Part of the reason is that we have been successfully shifting to telehealth over the course of 20 years and is now the largest telehealth provider in the state of South Carolina. Additionally, because we're a unified service delivery system, we're able to track centrally all of our services that are being delivered throughout the system and move assets as needed. Telehealth has certainly not been a panacea, as many of our patients live in areas with limited broadband coverage or do not have devices that adequately provide care or cellular plans that afford them the opportunity to connect full time. Thankfully, we're now fully operational and able to provide telemedicine as well as in-person care. We have found that our elderly population has adjusted very well to these changes. The challenges for providing care among aging populations are numerous. One of the biggest challenges has been an increase in substance use during the pandemic. Since federal funding for substance use and mental health care are often split at the federal level, developing programs that address these co-occurring issues is often difficult and challenging. Secondly, many organizations do not provide both mental health and medical services in the same location. As a result, many older Americans have to visit multiple locations in order to obtain services. Each additional visit increases the likelihood that they will not obtain services or will drop out of services. There are several areas where South Carolina has done an exemplary job. We have developed excellent partnerships with law enforcement to make sure that officers are provided the skills needed to identify and manage services in a mental health crisis. We have also increased our crisis intervention teams, where individuals are able to provide mental health care to the extent possible. South Carolina has been very committed to increasing services to our veteran population. The state has worked closely with the Department of Veterans Affairs to increase the number of veterans nursing homes in South Carolina. The blending of state funding and federal funding has allowed us to expand and make a difference. I appreciate the opportunity to appear before the committee today, and I am proud to lead the 4,300 individuals at the South Carolina Department of Mental Health who strive each day to provide both physical and mental health care to all South Carolinians. Thank you.
Dr. Rogers, thanks for your statement. And we'll turn next to Ms. Williams, and I just want to note the presence virtually, Senator Rick Scott. Ms. Williams.
Thank you, Chairman Casey, Ranking Member Scott, and members of the Special Committee on Aging for the opportunity to provide testimony on the important topic of mental health care for older adults. My name is Kimberly Williams, and I am the President and CEO of Vibrant Emotional Health, a non-for-profit organization based in New York City that reaches over 3.5 million people every year. We work every single day to help save lives and help people get care anytime, anywhere, and in any way that works for them. Vibrant leads a broad-based coalition in New York that develops and advocates for changes in policy and practice that are essential to meeting the mental health needs of older adults. Vibrant also serves as the administrator of the National Suicide Prevention Lifeline, which provides crisis support services for individuals, including older adults experiencing a mental health emergency. The country faces what has been termed an elder boom, or acknowledgement of the increased population growth of individuals aged 65 years and older. Older adults represent 54.1 million individuals, roughly 1 in 7 Americans. 20% of older adults aged 55 and older have a diagnosable mental health or substance use disorder, Sadly, most older adults with cognitive and behavioral disorders do not get adequate care and treatment. In addition, lower income older adults who are both covered by Medicare and Medicaid are forced to navigate two complex insurance systems, each of which have different coverage and payment rules. Today, I want to share with you the story of an older individual served by Vibrant through our Older Adult Assertive Community Treatment Team, a community-based model that addresses the needs of adults with serious mental illness. A 62-year-old Caucasian woman located in the Bronx, New York, was admitted into the ACT program with serious mental illness and co-occurring chronic physical issues. She did not have stable housing and was using psychiatric hospitals as a housing solution due to stigma and verbal abuse she experienced within shelters. The interdisciplinary team of providers delivered her weekly trauma-focused therapy and assistance with taking her psychiatric medications. Through these and other interventions, she was able to gain insight into her mental health condition, address her physical health needs, and utilize coping strategies. The ACT team advocated for her needs during appointments to ensure that she received appropriate treatment and resources. After a year in the program, her functioning improved enough to transition to a lower level of care. She voluntarily provides updates on her progress to the ACT team and is incorporating many of the skills and strategies she learned within the program. Her story is but one of many success stories which illustrate the power of providing comprehensive, integrated, recovery-oriented supports tailored to the unique needs of the older individual. By addressing challenges holistically, we are able to improve mental health outcomes and keep older adults thriving in the community, reducing the use of costly or inappropriate settings. As highlighted by this example, many older adults with mental health challenges also have chronic physical problems. Many older adults who seek treatment for late-onset mental health problems turn to their primary care physicians, making it critical to build linkages between mental health and physical health services and to design integrated service structures. Similarly, many of the needs of older adults with mental health problems are addressed through the aging service system. This system offers opportunities for prevention, identification, sites for community-based treatment, and more. Linkages and new integrated service models between mental health and aging services are key to better service provision. A number of other recommendations can be implemented at the federal, state, and local government levels to help improve older adult mental health care, including integrating mental health, substance use, physical health, and/or aging services, particularly for individuals who are eligible for both Medicare and Medicaid, improving access to mental health and substance use services, including disseminating best practices, addressing the shortage of clinically and culturally competent workforce, in part by recruiting and training more providers, and also in part by including older adults themselves through paid and volunteer roles, and restructuring how services are financed, particularly within Medicare and Medicaid, so they are affordable, enhance integrated care and treatment, expand the types of providers available, and support services in the home and community settings. Vibrant stands ready to partner with members of this committee, older adults with lived experience, and other stakeholders to implement these recommendations and improve mental health outcomes and quality of life for older Americans. Thank you again for your time and consideration of this very important topic.
Ms. Williams, thanks very much for your testimony. Senator Blumenthal has joined us, and we'll turn to our last witness, Jim Classen.
Good morning, Chairman Casey, Ranking Member Scott, and members of the Senate Special Committee on Aging. Thank you for allowing me to testify here today on the issue of older adults and mental health. My name is Jim Classen. I am an older adult, 73 years old, who lives with mental and physical health challenges and a substance use disorder. Fortunately, today I am a person in recovery. Let me also say that I'm grateful to the healthcare providers who cared for me when I needed it most. Professional intervention was necessary. However, it was not sufficient. What has sustained my recovery process over time has been what we call peer support. By peer support, I mean people who've been through it, helping others who are going through it. This can be done professionally with certified peer specialists or informally as well. But peer support is not where my story started. Even in my 20s, I knew something was wrong. Mental health challenges ran in my family. I did seek help and got some, but still there seemed to be difficulties I couldn't quite name. I moved to Philadelphia, Pennsylvania in 1986 for a great job opportunity, and that's when things really started to blossom in ways both good and not so good. The new job was wonderful, but the profound depression that descended in about 6 months' time, not so much. And to complicate matters, I started self-medicating in a very harmful way. I was a country kid who moved to the city, determined to have the great urban adventure. And what started as a party blossomed into a full-blown addiction. And I'm talking Philadelphia in the mid to late 80s, so we're talking about street drugs, the epidemic that preceded the current opioid crisis, and crack cocaine has not gone away by any means. What followed for several very difficult years were the devastating effects of my substance use on my family, the toughest part of my story to tell and for me to deal with to this day. Again, I sought help, but help then focused on the drug use. We know now that an integrated approach to addressing mental health and substance use is more effective at getting at both the immediate troubling behavior and the underlying causes. My challenge wasn't that it was one problem or even two. I was navigating through this debilitating depression. My diagnosis is bipolar disorder. At the time, just getting a grip on the substance use seemed to be the most immediate priority. Old school recovery just meant stop using. That wasn't enough, though, because I was using for a reason, although the exact underlying problem was not crystal clear, even to me. And a diagnosis does not fully explain why anyone uses drugs that dangerous and powerful. Over time, my recovery assumed a more comprehensive integrated approach, and as I aged, so apparently did the field. After several hospitalizations, many rehab after work programs, medications, and several therapists, I was introduced to a self-help approach with an emphasis on wellness and less on illness. This appealed to me. The first question was, what are you like when you're well? And I can assure you, no one at that time was asking me what I was like when I was well. They wanted to know what was wrong with me and why I was acting the way that I was. I felt hope. I felt connection with someone who possibly understood. Shortly thereafter, I met two people at a wellness conference who introduced me to the concept of peer support and that I could become a certified peer specialist and eventually a certified older adult peer specialist as well. So for 10 years now, I have been a CPS, right, certified peer specialist, and a COPES facilitator. Maybe the best thing is that I no longer have to manage these secret lives of addiction and mental health and mental illness. I can now share my experience without shame or stigma. Now, as an older adult myself, though, I can relate to the reluctance, embarrassment, and stigma that many do face in dealing with and disclosing such challenges. It is hard to talk about, but the population of older adults is growing, and we come with mental health, physical health, and yes, even substance use issues. From my personal experience and the experience of thousands of my peers and from research, we know that peer support is one solution and one that is beneficial and cost-effective. I am no expert on health policy, but I do share the concerns of other older adults for our future well-being. We have great programs, and we know a lot more now than in the past, but we need more support, and also more public awareness and education. I want to thank you for your time. I hope that sharing my lived experience with my mental health challenges and substance use can contribute, can help the policy and program conversation. And of course, I look forward to answering any questions. Thank you.
Well, thanks very much, Mr. Classen, for sharing your personal experience. That's always of great benefit, not only to those who are part of this hearing, but I think people well beyond this room, and we're grateful you're willing to do that. And I'm so grateful for all of our witnesses. Before I turn to our first set of questions, I'll start. I also want to acknowledge Senator Warnock is here with us at the hearing virtually. Jim, I'll start with you, and what I just mentioned about you sharing your story. You talked about that terrible word stigma, which just has enveloped so many of these issues for so long, and it becomes, I guess, a barrier for folks to seek help or to be able to overcome the challenge that they have. You had shared that that stigma led to self-medicating, and you described for us what that meant in your life, and that eventually you found the support you needed, and now you're able to help others, not only generally with these challenges, but also that help them with this issue of stigma. So I guess my first question is, what can we do, we meaning the United States Senate, the United States House, members of Congress, to address just that issue? There's lots to talk about, but that issue of stigma surrounding mental health, to ensure that older adults feel both comfortable in seeking care, but also supported when they try to avail themselves of that care.
Yeah, thank you. Thanks for that question, Senator Casey. I think there's a lot we all can do, but certainly, yes, in the Senate. I think that there's an issue of, just public awareness. Increasingly, we do see people coming out and talking about their mental health challenges and substance use challenges, whether celebrities or sports figures or at any level in our society. And I think every time that happens, it opens the door for someone to say, maybe it's okay for me to talk about this. Maybe it's okay for me to talk about this with my family, maybe in my community, my faith base, wherever it is. And I think it's just an incremental process.
Oh, maybe, is it the mic not on?
Oh, I'm sorry.
Maybe just,
Is it? Hold on. There it goes. It's on now.
okay. Maybe to just reiterate briefly what you just said. So
Yeah. Yes. Thank you for your question, Senator Casey. And what I was saying is, I think there's a lot that we can all do, and certainly, sure, it starts, at the top of our society and throughout. For folks who are willing to come out and talk about mental health and substance use, we see it increasingly. I think it is happening. But I also see in the media, right, in the mass media, mental health and substance abuse, there's just a lot of education that needs to happen.
no question about it. And I think that's true across the board. I wanted to, and I'll keep within my time because I know we want to get to other senators, but I wanted to ask a question of Dr. Emory Tubercio about these silos that we often identify with regard to mental health coverage for individuals when they have coverage both under Medicare and Medicaid. You described how navigating these two separate healthcare programs results in both confusion and unnecessary barriers to care. I mentioned references to Pennsylvania. We've got about 400,000 folks in our state who have both are enrolled in both programs. 9 million seniors and people with disabilities across the country, so it's a big number. So can you speak to how greater alignment of both programs would help older adults access quality mental health services?
Yes, thank you, Senator, for an important question. So you are well aware of the navigation of Medicare and Medicaid and how complex they are on their own, and much more complex when an older adult has to navigate both for many conditions. And so it's interesting, the legislation that you and Senator Scott have proposed to expand the PACE program may be a key to this work. So PACE programs provide highly integrated care, and as has been highlighted, the critical nature of integrated care for older adults to manage the entire benefit of dual eligible individuals, thus simplifying and significantly enhancing that care. But because PACE programs are often not real well equipped to manage mental health and substance abuse, one potential would be to manage those silos would be to create a partnership with HRSA and SAMHSA funded certified community behavioral health centers that may be ideal to assure that all of the home and community-based services provided by PACE and the specialty services provided by these CCBHCs may be able to effectively coordinate that care. And one critical element there as well is that additional training, perhaps by geriatric workforce enhancement programs, to both PACE programs and CCBHCs about older adult specific needs may be critical, and certainly the E4 Center would be happy to collaborate in that effort.
Doctor, thanks very much. I'll turn next to Ranking Member Scott.
Thank you, Chairman. I'd like to continue on the discussion of the dual eligibles. Dr. Rogers, can you explain the benefits of dual eligible integration and how this will help states improve care once it is implemented?
Absolutely. If you look at South Carolina, for example, and you've got someone that has a mental health crisis, they end up in a hospital. That is often going to be paid for through Medicare. But let's say that person needs to go into the community and they need wraparound services, they need services for if they're homeless, they need other services that may not be covered by Medicaid. Many of those are going to be covered by Medicare. Many of those are going to be covered by Medicaid in South Carolina. And so I think that figuring out how to blend federal dollars and state dollars has been one of the ways that South Carolina has been able to manage our way through that, because many of the services that now aren't blended, the state has actually stepped in to cover many of those services. And it usually is around areas such as social determinants, for example, coordination of care. For example, talked earlier about the fact that many individuals need medical care as well as psychiatric care. Much of that psychiatric care is not necessarily provided in a doctor's office, but may be provided in a community, may be provided in a community residential treatment facility. So finding ways to actually figure out how to blend funding to be able to have that integrated care in a single setting is often very, very important.
And Dr. Rogers, we're talking about nationwide, a significant population, nearly 12 million senior Americans are dual eligibles. And so this approach that we're seeking to establish through the AIM Act could have a tremendous impact on providing an enhanced level of care and assistance to those who may need it the most. Is that fairly accurate?
That's very, very accurate, because the problem we're seeing in South Carolina with having an elderly population there is the same problem that we're seeing around the entire country.
Yes.
It's state to state. Oftentimes you see that disaggregation of care because of the way it's currently funded. Absolutely.
Thank you, sir. Another question for you, Dr. Rogers, is I think through my opening comments about the important role that law enforcement plays in so many crises around the country, and specifically at home, the importance of finding a path to having co-responders, mental health experts, also responding to the challenges that law enforcement officers are responding to, seems to me to be a very important part of a new apparatus that could perhaps de-escalate. It's one of the reasons why I've worked with Senator Cornyn and many others on the Law Enforcement De-Escalation Training Act to find a way to help those two worlds come together in order to serve the communities who desperately need perhaps more assistance. Dr. Rogers, could you share the outcomes that have resulted from the partnership between the South Carolina Department of Mental Health and local law enforcement?
Absolutely. I think this is an area where we really have excelled as a state. Currently, we're embedded with 17 of our local law enforcement agencies in South Carolina. The things that we have seen is we have our crisis intervention teams, where we have officers that are actually going out with a trained clinician, usually a master's level clinician that's actually out with them in the field. If it's related to a mental health crisis, they're able to dually engage. We also have individuals who are in call centers, and so we're able to really triage those calls on the front end. For those areas that don't have an embedded clinician, we have mobile crisis that's available in all 46 counties in South Carolina. Those mobile crisis teams can be called out by a family, by law enforcement, really by anyone. That allows us to respond, I think, to anything that's coming up in a fairly short period of time. If we go out, for example, and it's a difficult situation, law enforcement will often clear the scene, make sure that it's a safe environment, and then mobile crisis will actually move in and continue to work with the family or individual, and allows the officer to really move on to something else. And then thirdly, something that we have done is we have what's called first teams. We recognize that law enforcement often are encountering individuals in very difficult times. Often there's not a place to talk about it. So as a department, one of the things that we have done is to develop mental health services specifically for first responders. And so those individuals are actually able to come to a different location, able to engage with therapists that are specifically trained to work with law enforcement agents throughout the state. And that has been a really incredible program that has benefited us a great deal. Frequently, law enforcement's engaging with folks that are at their worst. They're in crisis at the time. And so trying to figure out whatever we can do to be able to support law enforcement, as well as the individuals who are in crisis, has been something critical to us to do in terms of our law enforcement partnerships.
Thank you, Dr. Rogers. One of the things I'd like to say before I know my time's run out, Chairman, is the importance of that scene that you've just described, the ability to clear a scene, to let the mental health experts address the challenge. So often the folks who are calling the law enforcement officers to the scene are the family members who love the individual, who needs to figure out how to de-escalate the situation. I think that's one of the reasons why it's so important that we don't just sugarcoat the issue, but dig a little deeper into how we create an apparatus that actually works for the family who's trying to figure out how to de-escalate a situation, not to watch it explode in their very homes. So thank you very much for that answer. Chairman.
Thank you, Ranking Member Scott. I wanted to acknowledge as well Senator Braun with us at the hearing, and our next senator will be Senator Gillibrand, who's joining us virtually.
Thank you, Mr. Chairman. According to the National Center on Elder Abuse, approximately 1 in 10 older adults will become victims of elder abuse. Elder abuse has a physical, mental, and financial impact on older adults. A 2019 Centers for Disease Control Prevention report found that between 2002 and 2016, the non-fatal assault rate increased by 75.4% among men and 35.4% among women over the age of 60. And since 2020, crimes against older Asian American adults have become more prominent. This takes a toll on mental health. Racial discrimination and ageism can trigger chronic stress, anxiety, depression, and racial trauma. There's so much that needs to be done here, but funding for elder abuse and justice programs authorized under the Elder Abuse Prevention and Prosecution Act, Elder Justice Act, and the Older Americans Act is a first step. Dr. Emory Tubercio, there we go. How does racial discrimination and ageism affect someone's mental health, and what are steps that we can take to effectively detect, prevent, and treat elder abuse?
Thank you so much for that question, Senator. So interestingly, ageism is what prevents many older adults from getting screened in the first place. We are not aware that older adults are using drugs. As Jim so eloquently pointed out, this is happening. In fact, I treated a 75-year-old gentleman who started using drugs at age of 75 after retirement because he was bored. And the idea that we don't think our ageist ideas prevent us from thinking about older adults using substances, or our ageist beliefs that depression is a normal part of aging, it's not, are what prevent screening, assessment, and treatment from happening. And in fact, there are so many older adults, Senator Gillibrand, as you were pointing out, around elder abuse that are in their homes and we don't see them and we are not coordinating care into those homes. And so those folks end up being abused and not having their needs met. And so the degree to which ageism impacts our screening, assessment, and treatment, it's also impacted by racism. In fact, African American and other Black and brown folks are not assessed, not treated, not offered treatment, even among Medicare beneficiaries. And so it is critical that we address these issues by universal screening for depression, anxiety, substance use at a minimum, that we train community-based organizations to interact with older adults, like Meals on Wheels and homemakers who are going into the homes and potentially seeing some of these issues, and making substance use services universally available. And we can also address ageism by increasing awareness of it. And to Senator Casey's point about increasing awareness of mental health and aging, increasing awareness of ageism even with our language, with frameworks like Reframing Aging from the Gerontological Society of America. So thank you for identifying not only mental health and substance use stigma, but also ageism in this space.
And as you know, because of COVID, we've seen so much more mental health needs grow exponentially. What are some of the barriers that our older adults are facing with regard to accessing mental health services? Are there ways we can improve utilization of existing services? And for older adults on Medicaid, how could enhancing federal Medicaid funds to incentivize states to provide better community-based mental health services address the gaps in utilization?
So access to services is an enormous issue, particularly for Medicare and Medicaid, in part because Medicare Advantage plans have been allowed to split physical health and behavioral health services. And as they do that, then those folks who are seen in primary care are not able to be treated by psychologists like me who are embedded in that primary care clinic. And so as Dr. Rogers pointed out, as each successive referral that older adults get, they're less likely to connect to those services. And so if Medicare Advantage plans and Medicaid plans that are commercially available were encouraged or required to have more integrated care, that would increase access. That warm handoff inside the primary care clinic goes a long way to be able to assist that older adult to access services. And providing services in the communities where older adults are. We hear this in our policy academies, we hear this in our community conversations, that folks trust people in their own community, whether we're talking rural Pennsylvania or we're talking urban Chicago, that people in their community are folks that they trust. And so creating those collaborations between faith-based organizations, between area agencies on aging and senior centers to be able to increase access from both a financial standpoint with increased access to those services as well as the collaborations.
Thank you. Ms. Williams and Mr. Classen, just two follow-up questions if there's still time. Ms. Williams, given your experience with Vibrant Emotional Health, what are the benefits with peer support programs and community-based mental health services? How has this approach helped reduce stigma and support older adults receiving behavioral health care? And Mr. Classen, thank you so much for sharing your experiences. It takes extraordinary courage and is incredibly important to bring awareness to this issue. And if there's time, the chairman can tell me, because I can't see the clock, what are the key ways to reduce stigma and what are some examples of coverage gaps that you've experienced?
Yeah, I'm also hard of hearing. I'm not sure I have the question, but what I would like to say, because it just touches on, well, you know, what's been shared here with Dr. Rogers and Senator Scott. So I train folks with mental health challenges to help people to become peer specialists, and thinking especially about the mobile crisis teams and being, working with law enforcement and all of that. I had one guy named Will that we had trained as a peer specialist, and he got a job for a major provider, struggled a bit with case notes and using the computer, didn't get fired, got transferred. I started to get a new set of phone calls from psychologists that was on this mobile crisis team that he was on. And the message there was, we don't know how we did it without him. Because of his lived experience and presence, he was able to de-escalate situations that professionals may have been, challenged with.
Thank you. Ms. Williams, did you want to just answer the question that I asked you?
Thank you, Senator, for the question. Peer support has been incredibly powerful in terms of engaging older individuals that we serve and others in the community serve, in terms of destigmatizing access and being able to share their own stories of hope and recovery and build trusting relationships with other older individuals and engage them effectively in care. I speak very highly of the use of integrating peer support with existing services because it can effectively engage people in care and ensure that they get the treatment that they need.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Gillibrand. We're joined by Senator Kelly, and now we'll turn next to Senator Collins.
Thank you, Mr. Chairman. I want to thank both you and the ranking member for shining a spotlight on this problem. I think that when most people have an image of someone who's addicted, they think of a young male, and they don't think of an older person. And yet, from a previous hearing that I held 4 years ago when I chaired this committee, one of the witnesses told us that older adults make up 25% of the long-term opioid users, and that Medicare beneficiaries are the fastest growing population of diagnosed opioid use disorders. And the drug overdose crisis has only gotten worse since then. In my state in 2020, more than 630 people lost their lives to overdoses. Equally startling, however, is the fact that there were nearly 9,000 non-fatal overdoses. We also know that people 85 and older have the highest suicide rate of any group. So we have a real problem. And I think hearings like this help shine a spotlight on the problem facing older Americans. And building off what Ms. Williams said and Mr. Klassen's powerful testimony, I too want to endorse peer-to-peer counseling. I have visited the Bangor Area Recovery Network, which is a peer-to-peer program. It is very successful. But during COVID, there haven't been nearly as many face-to-face interactions. And I can see Mr. Classen nodding as I'm saying this. Did you have something you wanted to add?
Well, yes, that's true, but I think it accelerated us into a world of telehealth.
Yes.
And in some ways, we were able to reach people that we weren't able to before, people in rural areas that did have the technology or maybe reluctant to come to a physical place, we were able to reach. So kind of worked both ways.
Thank you for bringing up telehealth, because that leads me into my question, which I'd like to hear from the rest of the panel on. We know that during COVID that a lot of face-to-face counseling sessions were canceled, and we know that isolation and loneliness can have serious, even deadly consequences for the health and well-being of our seniors. It's associated with a greater incidence of depression, substance abuse, diabetes, heart disease. In fact, studies have shown that the health risks of prolonged isolation are comparable to smoking an astonishing 15 cigarettes a day. Just think about that. So this is a call to action. So I would like to ask Dr. Emory Tubercio. All of us are having a little trouble on the last name, for which I hope you'll excuse us, and Dr. Rogers and Ms. Williams about the role of telehealth. I've worked very hard in the infrastructure to get funding with Jean Shaheen so we can get it out to the rural areas, which exist in every state. How can we ensure that telehealth plays a role in increasing access to proper screening and care for older adults, especially in rural areas, as we grapple with the ongoing shortages in the behavioral health workforce? If we could go straight across. Thank you.
Thank you so much, Senator Collins. It's a critical question. I think particularly for older adults, we have a program that provides cellular-enabled tablets to older adults for accessing telehealth and for accessing social media so that they can connect. And that program has been incredibly powerful in reducing loneliness. Folks, though, who don't have that kind of a device or don't have access to broadband, as Dr. Rogers highlighted, that those are individuals who require telephonic psychotherapy and interventions to be able to even access their primary care. And the annual wellness visit that Medicare provides is a wonderful way to be able to offer that screening telephonically. But continuing that Medicare coverage for telephone-only services is critical. So many of my patients who I continue to see only via telephone would not get services otherwise. And as we move forward, even hopefully out of this pandemic, that continued service will allow my patients who may have increasing medical issues as well that won't let them come at any given time to continue to manage their mental health.
I agree with you that we need to extend the reimbursement for telehealth and audio as well. Dr. Rogers, you represent a state that has a lot of rural areas, the way Maine does. What has been your experience with telehealth?
You know, Dr. Emory Tubercio said something earlier that I hadn't really thought about as much, and that's the whole idea of ageism. One of the things that when we were first starting out with telehealth, there were kind of these two ideas. One is that older people don't use technology, and the second one is older people don't work because most of them are retired. One of the things that we found as we started rolling out telemedicine is that both of those things are false for the most part. We found that a lot of our elderly population continue to work. And one of the things that's been really beneficial about telemedicine is the fact that they don't have to actually miss work in order to have an appointment. In South Carolina, many of our folks are working hourly jobs. So if you're taking an hour off, oftentimes you're having to take an entire day off. Versus I've seen many people that are able to go out to their parking lot, sit in their car, have a 30-minute session with me, and then go back to work. That's a benefit for both the employer side, but also the employee, who happens in many cases to be age 65 or older.
I'm going to have to cut you off because I know I'm over my time, much as I'd like to continue this. Ms. Williams, could you provide me with an answer for the record, because I really am interested in what you have to say as well.
Yes, I'd be glad to. Thank you for the question, Senator Collins. Just quickly,
Yes.
So want to reinforce, right, the extension for telemental health reimbursement and audio-only available services. We've been able to support some innovative programming within New York that are easily replicable. For example, providing treatment over the phone to support and engage older adults and make sure that they get access to the care that they need. And also, working in partnership with the state of New York in the implementation of service demonstration grants, which have included providing supports to older individuals in rural communities who are isolated, being able to provide them access with a laptop so that they can get the treatment that they need. So both of those examples, serve as demonstration for the importance of making sure that we extend access to support.
Thank you. And thank you, Mr. Chairman. I also think that telehealth helps to reduce the unfortunate stigma that still exists when people can get the counseling and help they need in the privacy of their own homes. Thank you.
Senator Collins, thanks very much, and I agree. Senator Kelly.
Thank you, Mr. Chairman. I was going to follow up a little bit on Senator Collins' question. I think she covered the issue, opioid epidemic and substance use disorders and how it affects older adults, and like so many other states, I'm sure like Maine, Arizona has been hit pretty hard by this. And it's not surprising that we often hear from the aging network, for lack of a better term here, that they often hear from seniors asking about what sort of substance use disorder treatment that their Medicare plan will cover, and often they don't like the answer. So if there's anything you left out about where these gaps exist in Medicare for older adults experiencing substance use disorder issues, if you just wanted to take a few more, like maybe a minute or so to fill in the gaps there. And then I've got a question for Mr. Classen.
Thank you, Senator Kelly, for the question. As was highlighted, given the growing population, there's a growing need for these services, and Medicare, unfortunately, has limited coverage for substance use services. It's not in line with evidence-based practices and with the full treatment continuum. So there are remedies for addressing those gaps, including ensuring that the full continuum of services are covered, ensuring that the full range of addiction specialists and treatment facilities are covered, and ensuring that parity is applied here so that older adults don't experience unnecessary discrimination in financial and treatment limitations. And so through addressing those gaps, we can promote better access to care for older individuals and get more of them on the road to recovery.
Thank you. Mr. Classen, as a peer specialist, are there programs, are your programs covered by Medicare?
Some of them are, yes.
Some of them are, but some of them are not.
That's correct.
And my understanding is 60% of mental health professionals who work in rural areas, that their programs are not covered by Medicare. Does that sound about right to you?
That sounds about right.
And imagine how disruptive this would be, you know, for somebody who ages into Medicare, and then suddenly they find out that they can't pay their insurance. Medicare will not pay for the provider, and they have to pay out of pocket. And what this means to seniors in Arizona, and for them, it feels rather arbitrary. And they often don't have supplemental coverage needed to make this care affordable. So that's why I'm a co-sponsor of the Mental Health Access Improvement Act, which would allow licensed professional counselors and licensed marriage and family therapists to provide services under Medicare. We have to expand the universe of providers to make care accessible and affordable. I mean, literally, lives depend on this often. So, Mr. Classen, given your personal and professional experience, is there anything you'd like to add to that, speaking to the need to bolster our workforce and ensure the continuum of care continues into Medicare?
Yeah, thank you, Senator Kelly. Yeah, it's complicated, right? A lot of stuff goes into it. A lot of older adults are reluctant to ask for help to begin with, right? We're all about rugged individualism, and I don't need public benefits and all that. So part of it is relating with them on that issue. And then there's the frustration if I am seeking help and getting kicked around to different places, or the rules are different, or it just seems to be taking too long, folks just, abandon it. I think with peer support, it's an interesting idea. I think of peer support as more in direct service, but I think the idea that peers can talk to peers, older adults can talk to other older adults and relate with them, whether they're veterans or whether it's a substance abuse issue or whatever, and say, it's okay, and I have some information, I have some resources for you.
Well, thank you, Mr. Classen, and I yield back the remainder of my time.
Senator Kelly, thanks very much. We're at a point in the hearing where we'll have some senators coming to the hearing from other hearings they've had or returning to ask questions. In the interim, I'll start a second round. I can't guarantee, because of the vote coming up, that every senator will have a second round if they desire it, but I'll start until we have a senator returning. I wanted to go back to Ms. Williams. You said on page 3 of your testimony, you related a story of a 62-year-old woman living with serious mental illness and chronic health issues who also lack stable housing, which is, can't even imagine what some people have to live through when they're experiencing all kinds of challenges at the same time. You described how providing her tailored support unique to her mental and physical health, as well as her own social circumstances. As a result, she was able to get the care she needed in the community instead of a psychiatric hospital. And you go on to recommend better integration, as we've heard before, of physical and mental health care with aging services. I've got legislation I made a reference to earlier, the Supporting States in Integrating Medicare and Medicaid Act, which would provide $300 million to states and the CMS, Centers for Medicare and Medicaid Services, to develop and advance these integrated programs. And I guess a simple question about this kind of an approach: what's the value of that linkage, linking community-based services with medical care?
Thank you, Chair Casey, for this really important question. As has been highlighted, older individuals who have chronic physical conditions and functional impairments, right, they are more likely to experience higher cost services, more likely to experience poor outcomes. And so to engage better with older adults will lead to better health outcomes. And that includes by linking with social services, particularly around prevention and wellness. So medical providers can work collaboratively with area agencies on aging to help to support older adults in managing their chronic conditions and also to help address, unmet social needs. And so it's through this linkage between social and medical that we can support the overall quality of life of older individuals, support better health and mental health outcomes, thus reducing the need for more costly services like nursing homes and other institutional settings.
Thanks very much. We'll turn next to Senator Blumenthal.
Thank you very much, Senator Casey, and thank you for holding this hearing. I am grateful to the witnesses for being here today on this tremendously important topic. As my colleagues may have remarked, and I apologize if I'm repeating anything they've said or asked, I think this nation is going through a mental health crisis. The trauma of COVID, the economic challenges faced by families, the deaths and illness that they've seen at every age, most especially our children, because they have been out of school, but really every age. And I fear our elderly Americans as much as children, even though they are perhaps less vocal and they are more isolated. But I'm particularly concerned, and I've just left a hearing of the Armed Services Committee. I'm on that committee and the Veterans Affairs Committee, by the mental health of our veterans. We're only really beginning to understand how the impacts of trauma, seeing it, enduring it during military service, can be enduring and, in fact, can be increasing as age comes on. We now have a sizable veterans community of advanced age due to the wonders of medical care. They're living longer. But I wonder if the witnesses could comment on the needs and challenges faced by veterans as they age and what you've observed about the challenges they face and the programs that are available to them.
Well, certainly, Senator, as you highlighted, we are only just beginning to understand trauma in later life. And there are many older adults who experience the effects of trauma for the first time after retirement. They've been working for years and engaged in childcare and engaged in family, and when they slow down enough, sometimes those traumas resurface. And that may be particularly the case for veterans. I happened to be working at the VA Boston Health System at the time of 9/11 and working in the nursing home, watching veterans watch the television and being incredibly distressed that A, from their nursing home beds, they were going to be called back into service, and B, reliving those kinds of events over and over. And so as we watch things like the Ukraine war, the Russian attack on the Ukraine, so many veterans are experiencing those same traumas, and so increasing availability of services. Certainly the VA has an incredibly powerful trauma center that has fantastic evidence-based programs, and there are some veterans who are not service-connected enough to be able to access those services effectively, and so assuring that those services are available in the community as well would be well regarded. Thank you.
Thank you. Any other comments?
Yeah, I think in addition to the services that we know are needed by our vets, one of the things that we talked about earlier was the fact that we have a shortage of providers. So if you look at our older population and folks that are specifically trained to work in the geriatric area, we're seeing many of those folks retiring or not as many coming out of training. And so I think that part of what we're seeing is really a twofold issue. One is increase in need that we're seeing among the veteran population as it ages, but also the second piece is really not having enough trained people going into those areas to work with older adults.
Thanks, Dr. Rogers.
Thank you, Senator Blumenthal, for the question. Just to add to what has been noted, particularly, Dr. Emory's comment around ensuring that community-based providers are equipped to support older adults with mental health issues. For those who are veterans, ensuring that those providers are trained adequately to identify and support the specific issues that veterans who are older are experiencing.
Thank you.
Try to quickly.
Sure.
I mean, no one can talk to a veteran like another veteran. I'm not a veteran, but one of my co-facilitators, a Marine with significant military experience and is a peer specialist. I mean, just to me, it was a very powerful combination.
That's an excellent point. We've been trying to expand the peer-to-peer program, but as you point out, there's no one like one veteran talking to another veteran, so nothing like that kind of rapport and trust. Thank you. Thanks, Mr. Chairman.
Thanks, Senator Blumenthal. Ranking Member Scott.
I think to add on to Senator Blumenthal's rapport and trust, it's having had the same experience in so many ways, while different, the similarities of being in conflict, being in theater, also adds to the ability to have someone who understands and appreciates the significant impact that life and or serving your country has had. Having a father who served 27 years and a brother who served 32 years and my other brother who served 26 years, I oftentimes hear the stories of how important it is to have someone who's been where you are, have walked in your boots there with you going through the journey. And Dr. Rogers, one of the things that I note is in South Carolina, we have Victory House in Walterboro and other facilities for our veterans. The availability of space and capacity seems to be one of the challenges that we face nationwide. Would you talk, Dr. Rogers, for a minute about the importance of nursing homes and other veteran facilities in South Carolina, ensuring this population are receiving adequate mental health services?
Absolutely. Thank you for that question, Senator Scott. One of the things that we have in South Carolina is we're actually in the process of building our 5th veterans nursing home in the state. South Carolina is organized a little differently than many other states in that our veterans nursing homes actually fall under the Department of Mental Health. And part of that is because the first nursing home that was opened in South Carolina to serve veterans in 1971 was opened by the department because we were trying to move people from the state hospital that were veterans. And many of those folks had significant mental health issues, but many really did not. And so over time, we've developed some degree of expertise. And part of that expertise is really figuring out how do we have the resources to really work with our older veteran population. So we have a number of veterans who are actually working in our system. We also have a number of geriatric psychiatrists, psychologists that are actually working with us specifically with the veteran population. So for example, the deputy director in our department oversees our nursing homes as a geriatric psychiatrist. Who is very engaged and involved in making sure that the mental health service needs are met for that population. And so that focus on the veteran population as well as the aging population has been something that the department has been very focused on.
Thank you, sir. Switching to another topic, Dr. Tubercio, close enough?
Close enough.
How do you actually pronounce it, though?
Emory Tubercio.
Tubercio. Yes. Thank you, Doctor. The issue of overdose is plaguing our nation in a way that we've not seen ever. 107,000 deaths, as we talked about earlier, and the challenge of fentanyl coming across. I can't tell you the number of parents that I've talked to who've lost their child because of the first try with something that was laced with fentanyl, and the number of our seniors who are having a similar experience as well. Can you talk for a minute about the importance of this missed challenge that we're facing?
Absolutely. Thank you for raising that important topic. You know, it's interesting. There was a study that just came out that looked at the last 10 years of data and demonstrated a 1,886% increase in opioid overdose deaths. And that another report just came out showing that adults aged 65 to 74 face the largest increase in the drug death rate of any age group. So this is an older adult issue. And interestingly, as we look at older adults in particular and why this is an issue, ageism is a piece. As I've said previously, this idea that we don't look at older adults and think drug use, so we don't screen, so we don't assess, so we don't treat. And the idea that part of this is also driven, a part of that data, the authors of that JAMA study pointed to racism as being a key factor, that older Black men died at a rate 10 times that of other groups. And older Black men, as Senator Blumenthal was just bringing up trauma, older Black men are much more likely to be victims of trauma, including a lifelong experience of racial trauma, lack of access to health care, and don't trust health providers for good reasons. Black and brown folks in hospitals don't get treated for their pain as much as white folks. And so with that, folks are more likely to self-medicate, as Jim has highlighted. And so again, we need to be screening, we need to be assessing, we need to be providing these services. And I would be remiss if I didn't also point out that in addition to opioids, alcohol is actually the most abused substance by older adults in the US, and we don't provide nearly enough attention to that as well. And particularly during the pandemic, the issue has exploded.
Thank you, ma'am. Mr. Chairman.
Thank you, Ranking Member Scott. I want to thank all of our witnesses. We're going to have to adjourn, but we could go on for a good while with all of the expertise that you bring to bear and your own either personal experiences or professional expertise, and in many cases both. We're grateful for the work you've done to bring that level of insight and expertise to the hearing today. I want to start by, as well, thanking Ranking Member Scott for hosting this hearing with me today and to elevate the need to improve mental health care for older adults. As we heard today, seniors face many challenges in just navigating the mental health system, including limited awareness about where to look for help and the stigma surrounding mental illness and treatment, stigma as it relates to both illness and treatment. These challenges lead these individuals, these Americans, to feel unsupported and very much alone and nowhere to turn. There are people like Jim who've shared his story with the committee today and tells us why we need to have a more integrated approach to mental health and substance use disorder for older adults. And that's one of the reasons that Ranking Member Scott and I have introduced the Advancing Integration in Medicare and Medicaid Act. I'll use the acronym, the AIM Act, which requires states to develop a plan to address fragmentation in both Medicare and Medicaid. These programs, which so many older adults rely upon for their mental health, both programs become so essential for people's lives, and we got to make sure they're better integrated. So I look forward to continuing to elevate solutions to our nation's mental health crisis, including solutions to help our seniors. And now I'll turn to Ranking Member Scott for his concluding statement.
Thank you, Chairman, for holding another really important hearing to all of our witnesses today. Thank you for sharing your expertise and, frankly, your passion, as well as your experience on such an important topic, especially during the week where we celebrate Older Americans Mental Health Awareness Day. Whether it's the AIM Act that I've introduced with the assistance of Chairman Casey, or the Academic Act, or the Law Enforcement De-Escalation Training Act, the one thing that I'm confident of is that we are taking this issue more seriously today than we have in the past, and that's really good news for the future. But far too little has been done, and we need to push forward in making sure that we pass meaningful legislation that provides more resources to our senior population. And America is only growing older, which means that the problem will only get worse unless we bring more solutions to the table now. Thank you all for being here.
Ranking Member Scott, thank you. And again, I want to thank all of our witnesses for their testimony, the answers to the questions they provided, and of course their own expertise that they'll continue to bring to bear on these issues. For the record, if any senators have additional questions for witnesses or statements to be added to the record, the hearing record will be kept open for 7 days until next Thursday, May 26th. So thanks everyone for participating, and this concludes today's